my talk this morning is on imaging for high-risk prostate cancer, talking both about what's in the guidelines and then hopefully what is beyond. For this talk, these are my disclosures. None of them are related to any of the content that I'm going to be covering in the next 20 minutes. And I really have four objectives in this talk. The first is really to level set everybody and sort of define what is high-risk prostate cancer when I'm using that term. The second is to talk about what is the conventional imaging that we use to stage patients with high-risk prostate cancer. Then use that as a dovetail to talk about what's new and what's on the horizon, which is PET imaging for localized high-risk disease. And then I'd like to finish talking about theranostics, which is taking advantage of PET imaging and then trying to deliver local therapy to sites of disease. So let's start with the first of these, defining high-risk prostate cancer. So if you look at the American Cancer Society, the statistics are in 2023, there's going to be about 290,000 new cases of prostate cancer diagnosed, and about 20 to 30% of these new diagnoses are going to be high-risk prostate cancer. It appears that the distribution of high-risk prostate cancer and metastatic disease is increasing. It's been postulated that some of this may be due to the 2012 to 2018 USPSTF recommendations about screening or not screening for prostate cancer, and therefore the resultant effects of that. Now, one of the important things to recognize are there are different schemes for defining what is high-risk prostate cancer, and they have similarities, but they do have some differences. But in general, they're basically predicated on clinical variables, and really three clinical variables. Histologically, what does it look like on biopsy? So that's your Gleason sum score, your grade. Number two, what's the PSA? And number three, the rectal examination. And we talked a little bit yesterday about how rectal examination can be variable between different persons. So these are sort of some of the big consensus panels and guidelines panels on the definition of high-risk prostate cancer. I'll just sort of walk through some of them and highlight a few of the differences. So if we start with the AUA's definition, it's Gleason sum score greater than 8 or grade group 4 or 5, PSA greater than 20, clinical T2C or greater. Slightly different than what you see from the EAU and the NCCN guidelines. Now these are, again, PSA greater than 20, Gleason sum score 8 or grade group 4 or 5, as well as clinical T3A or greater. And then the NCCN further subdivides this into a very high-risk cohort. And a very high-risk cohort are those with clinical T3B, clinical T4, or really a preponderance of high-volume, high-grade prostate cancer. And then probably the one that's really sort of different from the others is the RTOG, which is the Radiation Therapy Oncology Group. And their criteria, as you can see, are sort of a blend between some lower Gleason sum scores as well as those that may have higher clinical stage as well as node positivity. So why am I sort of bringing this point up? This is a really good paper from Memorial Sloan Kettering that took 4,000 patients who underwent a radical prostatectomy. And what they did was they looked at different definitions of what high-risk prostate cancer were. And they said, well, let's just apply this and see how would our population change if we apply definition 1 through 8 to our group. And what they found was a lot of variability. In fact, their surgical population, the high-risk cohort, ranged anywhere from 3 to 38%, depending upon what definition you use for high-risk prostate cancer. And if you looked at the outcomes after prostate cancer, the 5-year probability of disease-free survival was 49 to 80%. So I think my take-home message from this part is we probably need to have more standardized definitions, and I think we're getting there, but I think if we don't have standard definitions, I think interpretation of the data is difficult. So we've sort of set on, all right, what are the definition, what is high-risk prostate cancer? Let's talk now about what is the conventional imaging, 2022, 2023, and then we'll go on to PET imaging. So what's the goals of imaging? Number one, define the extent of disease, locally, regionally, as well as the presence of metastasis. Number two, if we can, characterize the tumor, get some local tumor anatomy. And then obviously it sort of helps in the global decision-making process on what do you choose for therapy and whether this person may or may not need multimodal therapy to treat their disease. So this is from the AUA SUO ASTRO guideline. This is from 2018, guideline statement number 22, which says clinicians should stage high-risk localized prostate cancer with cross-sectional imaging, CT or MRI, and bone scan. Now, here's the important caveat to that. This is going to be probably revised. So we have new guidelines coming out. 2023 in May, they're going to be released at the annual meeting, and I suspect, based on what we're seeing from the NCCN guidelines, that some of this may evolve as we look at the new guidelines that are coming out. But let's just take sort of the pros and the cons of what we have as conventional imaging. So what's the pros of CT? Look, it's widely available. We can all get it. It's fairly well standardized, the protocols. It's relatively low cost. It's a quick study for patients. And you can actually detect lytic and blastic lesions. Blastic is really what matters more for prostate cancer. And you have pretty good characterization of visceral anatomy. What's the disadvantages? Ionizing radiation, iodine-based contrast, and really I think what you have is some limited ability to characterize lymph node positivity, especially in sub-centimeter lymph nodes. What has really become more of my go-to with regards to local anatomy and staging for conventional imaging is really MRI. And why do I use MRI? Well, I think a few reasons. Number one, gadolinium is much better tolerated in general than iodine-based contrast. There's no ionizing radiation. And I think you get superior anatomy of the prostate and the local prostate anatomy when compared to CT, while still being able to capture some of the details with regards to lymph node metastasis and bony disease. What's the disadvantage? Look, patients have to sit in the machine for a long time. It's about 45 to 60 minutes. Claustrophobia may be an issue. And again, I'm going to go back to this concept that characterization of sub-centimeter lymph nodes on axial conventional imaging is limited. So we've talked about this a little bit, and I think, we get more and more of these MRIs in the pre-biopsy setting like we talked about yesterday, but even if you look at what information can we get on local tissue anatomy, I think very good performance characteristics to look at extraprostatic extension, as I've shown here, and even for those to be able to distinguish presence of seminal vesicle invasion. And again, that may not impact us as much surgically, but I do think that if a patient has been radiologically upstaged to have seminal vesicle invasion, it may impact how radiation therapy, and particularly the use of concurrent androgen deprivation, may be used. This is the point I'm going to keep coming back to, which is conventional imaging does not stage lymph nodes very well, particularly when they're sub-centimeter. So this is a very nice study that looked at over 4,000 patients. 650 had positive lymph nodes. And on preoperative CT, only 105 patients, or 2.5%, had a positive pre-op CT based on size criteria. So if you look at the performance characteristics of CT to pick up lymph nodes that were positive, the sensitivity was 7%. Okay, so I just want you to remember that number for later in my talk, 7%. And why is that? Look, most surgical series, when you're operating on patients, they don't have grossly positive lymph nodes, so the lymph nodes that are coming back positive are probably microscopic in nature. To sort of close out the conventional imaging side of things, we have the technetium bone scan. It's probably what we all use quite readily in practice, very available, very cost-effective, very standardized, and excellent for blastic metastasis, not so much for lytic metastases. Again, not so much of an issue for prostate cancer. What's the downside of it? Well, I think it's really nonspecific. It's blastic changes. So that could be an old fracture, or it could be prostate cancer metastasis. So we do have some variability there. And then it's a pretty long test. I mean, you have to get injected, and then they get their imaging about 4 hours later. So I kind of want to use that framework to sort of bring you up to speed on the 2023, so these were just issued in January of this year, the 2023 NCCN guidelines for prostate cancer. And again, I'm going to sort of focus on the staging of high-risk disease. So take-home point number one is we're kind of moving beyond CT and MRI and bone scan. And I would start by saying, let's just say your hospital or your health system doesn't have access to novel imaging. That's okay. So the NCCN guidelines still say that high-risk prostate cancer can get staged with CT or MRI as well as with bone scan. The one thing they do mention, if you look on the far right hand, is multiparametric MRI is actually preferred to CT, probably for some of the reasons that I shared with you, for local tissue anatomy and sort of staging the pelvis comparatively. But where we really start seeing some changes now with the new guidelines from the NCCN is really this concept of PET imaging for prostate cancer. So broadly speaking, I think if you look at PET imaging, it has the highest sensitivity and specificity of any imaging modality, but it really doesn't have very good spatial resolution. So you really need to couple a PET with some type of refined imaging that gives you better axial quality. So that's either a CT or an MRI. I think in most cases, it's a CT that we have in clinical practice. And we're going to talk about the role in initial staging and then recurrence of disease, whether that be local recurrence or distant recurrence or metastasis. So PSMA is really become the forefront of what we're talking about here. It's probably one of the best oncologic targets, outside of even urology. It's expressed in about 95% of prostate tissue, whether it be de novo tumor in the prostate or metastatic disease. But it's important to recognize there are areas that express PSMA outside of prostate. So you've got a number of different glands: parotid gland, salivary gland, lacrimal glands. You have the sympathetic trunk that can express it as well as the brain and the intestines. And the great thing about PSMA is it has a very large extracellular domain, so it's an easy target for binding. So these are the 5 FDA-approved PET imaging agents for prostate cancer. It includes 2 PSMA-based activities. One is the gallium-11 PSMA. The other is F-18 Polarify. I can't really pronounce the trade name, but it's Polarify, which is also a PSMA-based agent. And then you have 3 others: C11 choline, F-18 fluciclovine, which is ex-human, and then you have F-18 sodium fluoride, which is really for bony disease. One of the key points here is that only the 2 PSMA-based agents are FDA approved for initial staging of prostate cancer as well as recurrence of disease. While if you look at fluciclovine as well as C11 choline, these are really for recurrent disease, and then sodium fluoride is really for equivocal bone scans trying to better characterize the nature. The other important point is that when you look at the performance characteristics of gallium PSMA versus Polarify, which is another PSMA compound, there's really no significant difference in performance characteristics. So the NCCN panel did not distinguish between using agent A or using agent B when you're incorporating it as part of your treatment algorithm. So how does this work? 69-year-old patient, very commonly that we see 5 + 4 = 9 on biopsy, PSA of 18.5. If you look on the right-hand side, that's the T2-weighted MRI, and you can see fairly innocuous appearing lymph nodes in the left hemipelvis, but indeed when you get your PSMA PET scan, you can see you have a PET-avid lesion, and obviously when you fuse the images, it becomes more clear. This patient ended up having a radical prostatectomy. We can certainly speak later on today about what do we do with these patients who now we suddenly are detecting positive lymph nodes on PSMA-based testing and how we address them. But this patient had a radical prostatectomy, and indeed the pathology did show that this was a sub-centimeter positive lymph node. So what does the NCCN say? So it says basically, if you have unfavorable intermediate risk, high risk, or very high-risk prostate cancer, and you have a life expectancy of greater than 5 years, that you can and you probably should be getting, obviously, some type of imaging, but the preferred imaging now is PSMA-based PET-CT versus conventional imaging, and you do not need to get conventional imaging in the form of CT, MRI, or bone scan before getting a PSMA PET-CT, and it's really maybe the most effective frontline imaging study in this patient cohort. What is some of the data underlying this? This is a really nice paper from Hoffman and colleagues in Lancet, published in 2022. 302 men randomized to conventional imaging versus PSMA PET-CT prior to therapy. So these are patients that were going to either undergo radiation therapy or surgery. And what you can see when you look at the performance characteristics is the red is PSMA PET, the blue is conventional imaging. And when you look at identifying disease that is in the lymph nodes or metastasis, PSMA PET was superior across all groups. More superior accuracy, slightly higher specificity, and significantly higher sensitivity. One of the critical elements here is recognizing that you need to be able to interpret your studies. So you have to think about, number one, how bright or what is the SUV of these uptake sites, because there are normal physiologic areas that will take up PSMA. So simply seeing nonspecific activity with low SUV units probably is just nonspecific activity. So I think the 2 key take-home points is, does the story make sense? Is this an area which would be a landing zone for where prostate cancer can go to? And second, look at the SUV. Typically, about 6 or 8 is the recommended threshold for what would be considered a positive site of metastasis with an SUV uptake. So what do you do if you get a PSMA PET scan it shows no evidence of metastatic disease, and you're deciding to take this patient for, say, a radical prostatectomy. Do you actually have to take out the lymph nodes, or can you say, look, the lymph nodes look fine on imaging, I don't need to do that, I can just take out the prostate? Well, this is a really nice study from JAMA Oncology, published in 2021, that basically looked at a surgical cohort undergoing radical prostatectomy and looked at all of these patients who had a PSMA PET prior to surgery. And what they identified from 3 expert readers is that the sensitivity for lymph node metastasis was 40%. So again, I showed you 7% earlier for conventional imaging. 7's gotten better to 40, but 40 is really not enough to say, all right, well, we don't need to do anything with the lymph nodes. So I think it kind of encourages, once again, that when you look at this, you cannot obviate doing lymph nodes. I think when you're looking at radiation therapy, that's high-risk disease, you cannot obviate potentially giving radiation therapy to lymph nodes as well. I'd like to finish in talking about the concept of theranostics. So the whole idea of theranostics is you have a cancer cell, you have a cancer target, such as PSMA, then you have a targeting agent that binds to that extracellular domain, and then you have a link, and then you have a radioactive nuclide that's compounded to it, thereby being able to deliver very focused and specific targeted therapy. So how does all this fit in together? So I've been talking a lot about diagnosis, PSMA-based imaging for the initial staging and in the diagnostic realm of prostate cancer. I didn't have time in my talk, but obviously there's a whole separate element looking at secondary staging, which is those who've had recurrent disease after primary therapy and using PSMA-based imaging to characterize their disease recurrence. But now the third is therapy, using this and harnessing this technology to deliver therapy to regions of interest. So in the realm of theranostics, we really have sort of 2 agents. FDA approved almost 10 years ago is radium-223, and now the new kid on the block is lutetium-177 PSMA. So just for everyone's information, as many of you know, radium-223 is currently FDA approved for castrate-resistant metastatic prostate cancer to the bone only without evidence of visceral metastasis. But let's talk about lutetium PSMA. So here's sort of the schematic of how it works. You have PSMA, which is the green receptor being expressed. You have the PSMA ligand that binds to it. You have a linking agent, and then lutetium is the radioactive nuclide. So it binds to PSMA. It's intracellularized. It goes into the nucleus of the cancer cell, and then the radioactivity basically denatures and intercalates into the DNA strand, causing cell death. Remember, as I said to you earlier, PSMA is also expressed in normal tissue, so there is some inherent toxicity from giving this. It will kill cancer cells, but it may also target normal cells as well. So the early experience with PSMA was really in lutetium and the PSMA was really in these heroic cases. Castrate-resistant prostate cancer. They'd failed first-line and second-line anti-androgen therapy. They'd failed chemotherapy. I just talked about radium-223, and they had failed that. And so you gave this in sort of a heroic sense, and there were very positive responses for it, and it sort of set the stage for a trial. So I think the trial that's really important for everyone to know is the VISION trial. This was published in the New England Journal of Medicine in 2021. Oliver Sartor is the lead author for it. It's a randomized open-label phase 3 trial randomizing patients with castrate-resistant metastatic prostate cancer to either standard of care, whatever that might be, any of the agents for standard of care, versus lutetium-177 lutetium PSMA. What did they identify? If you looked at imaging-based progression-free survival, the cohort that got 177 lutetium had significantly improved radiographic progression-free survival. But more importantly, if you actually look at overall survival, the hazard ratio for the group that was getting the lutetium-177 was 0.62. So they had a 38% improved overall survival compared to standard of care. And so this agent's Pluvicto. We've been using it in our hospital for about 9 months now, and it has really tremendous responses. And I suspect this is going to be one of those agents that continually evolves over time. So my conclusions are, I think that conventional imaging continues to change over time. MRI is superior to CT for local tissue anatomy. They're both suboptimal for characterization of lymph nodes. PET-CT-based imaging, I do believe, is the future both for primary staging as well as recurrent disease after therapy. And I really think theranostics is an emerging field for targeted therapy, not only in refractory cases, but perhaps it's going to move earlier into the treatment algorithms as time goes on. Thank you very much.